So we talked a lot about many aspects of VBC today. So the operational component, including much discussion this year around AI, which was very interesting. There's still a people component in the organization. And then there's the financial piece, which the actuarial involvement part of it. So how do you see all three of those coming together to help scale? I'll give the one example that we heard today in the other breakout session on clinician. There's a lot of AI happenings in the clinical space that's giving physicians a lot more time now because their notes are being taken automatically. So give them a few more hours every day. There's also, they can go out and look up the latest in research to know how to talk to patients with the latest in, what's that called, care pathways and such. So there's a lot happening out there. So what they're saying is the level of quality between the physicians is getting a lot tighter, and that's going to make the human piece even that much more important. So I think that's what I took away from that. So what are your thoughts?
Yeah, I thought I want to quote Mark, who's the Chief Value Officer at UNC. We had a conversation yesterday, and he said something really interesting, and we were joking about this. We think we both earned honorary PhDs in organizational psychology, right? Because implementing value-based care, it's both a technical and an adaptive problem, right? And you've seen a lot of smart people up here talk about all the different models and the benchmarking, and I love you, my actuaries, right? Like you're waiting with bated breath for the ACO lead benchmark details. Me too. Mm-hmm. But at the end of the day, it's also about convincing physicians, organizing ourselves, redesigning care pathways. It's both and I think we forget that sometimes. It's really an organizational transformation that we're going to have to do practice by practice by practice. Mm-hmm. And Mark will tell you, in a large system where he has 20 hospitals, I believe, all of his hospitals are different. Mm-hmm. So what works for one hospital to convince people, it's maybe not gonna work over here. And I think we don't give each other enough grace about how that happens. But I think there's a flip side to this. I spent all day listening to really great points of light, right? Our opening moderator said, well, when I look at the cost curve, it hasn't bent. You're right. But when you look around the audience, you can hear really great specific examples, right? Something that was working for ESRD populations, something that was working for a pediatric population, right? What we're missing in this country is a scalable way to share those insights with each other.